For epilepsy, there is hope. Hey podcast listeners, Tori Robinson here for Epilepsy Sparks Insights, a podcast about epilepsy, epilepsy research, common comorbidities and all of the fascinating science behind it. Whether you have epilepsy, are a family member, a neurologist, neuropsychiatrist, therapist, neurophysiologist, scientist or researcher, Epilepsy Sparks Insights is designed to help you learn more about epilepsy from the other side of the table. I'm a person with epilepsy and some missing brain tissue. I hope to help bridge the unnecessary gap between patients, the public, and the aforementioned. Because epilepsy research and science are cool. Last week, we spoke with Kristen Goodell, a neuroscience PhD candidate at the University of Cincinnati, Ohio, who, as well as studying epilepsy professionally, also has refractory epilepsy. So she knows quite a bit more about the topic than many in the lab. Today we are talking to Dr Colin Dunkley, both a consultant paediatrician specialising in epilepsy and the Epilepsy 12 clinical lead, based at Sherwood Forest Hospitals in the UK. Colin trained in Leeds, then Nottinghamshire, had an epilepsy fellowship at Great Ormond Street Hospital in London, and since 2005 has been a consultant. His focuses are the epilepsies and quality improvement. Hello Colin!
Hello.
Can you tell everybody about yourself, please, and what you do?
Yeah, so I'm a paediatrician. I work in Mansfield, Nottinghamshire, just north of Nottingham. And I do maybe half of my time is about epilepsy related, and then the other half is general paediatrics. And I do a bit of governance related work. So I look after some aspects of pregnancy and maternity and gynecology, but that's not much of my job. It's mainly paediatrics, mainly children, mainly epilepsy.
How old are these children that you look after?
From day one up till adults, 19. Usually we're well on the way to getting them into an adult service, but it can be up to 19 years.
How did you start focusing on the epilepsies more than other neurological conditions?
Curiosity, I think. Yeah, I mean, it's hard to trace it back to that moment.
Yeah,
it was when I was doing community paediatrics, I think, in around here actually, and I was struck by how little I knew about epilepsy. It was a strange problem to have to try and help families with, and I felt quite overwhelmed by it. And I thought it would be easy to sort out by reading a book and learning, in the standard way about epilepsy, but it was extraordinary how difficult it was to get my head around it, and that got me curious. And I loved the fact that a lot of it was around discussion and conversation and finding out, and sort of an investigative detective type element to making the diagnosis, and then the ongoing care of families was again trying to understand their epilepsy, their views about seizures, their perception of risk, how it was affecting them. So it was very different from child to child. So I liked sort of appealed to my curious side, I think. And then I haven't been able to let go of it. It's sort of grown since then.
It's such a complex area, isn't it? And sometimes I feel like, and lots of other clinicians and scientists have told me, that it feels like we're just touching the surface. Like the human brain is so complex, and how it affects all other bits of our body, brain health, all that type of thing.
Yeah, for sure. And when you're communicating with someone, you're literally talking to you're talking to their brain. It's the organ of interest that you're speaking to, and we sort of pretend to understand it, but we don't really.
Do you know when people say that, it's like it's really reassuring, like your modesty, but also the openness. I think it shows openness to what patients and families have got to say, and valuing that. Sometimes it's a bit scary as well, like, oh, but you're a doc, surely you know everything. And no, I really don't. I think that can be hard for people to get their head around sometimes. Like, you are this medical professional, but wow, you don't know everything. I think that can be scary for some families, maybe.
Yeah, very much so. And it needs trust, I think, if you're going to be honest and show that you're not sure and not completely certain, and you're, going to be on this journey with the family, that takes a lot of trust, and you can easily you can easily oversimplify it or pretend you know all the answers and say this is definitely where we're at and definitely what's going to happen, but you sort of lose that trust if you go down that path. So yeah, a lot of it to me is trying to impart confidence in the family, but being honest about uncertainties and what you do and don't know, and then starting from there, I guess.
Could you give us examples of your patients, please? So, like, I know that's probably like quite a hard question to answer, but like, what are maybe extremes? So you have like little babies, and then you have people 18, 19, varying degrees of the severity of the epilepsies and comorbidities.
Yeah, so you can have a clinic where you're seeing a family with a little baby who's had some type of episodes in the first few days of life or when they're on the neonatal unit, and what is that telling you? And maybe the seizures are fine, but now you're thinking, what's their development like? Are they sitting? Are they smiling? Are they where what's the impact? Is there something else going on here? And then you can have a slightly older child, and you're thinking, is this spasms, which is really important to find in these under ones, and they can mimic lots of other problems, like reflux or funny shuddering episodes. So yeah, you might have a slightly older child, and then you might have a toddler running around, and what sort of funny episodes are they having at night? Have they got autism? What else is going on? And then teenagers, of course, which
own challenges there.
So it's completely different. But increasingly over time, we've tried to pull the teenage epilepsy people out of the standard clinics. I've found they need such a different type of package and approach. We've tried to have epilepsy clinics and then teenage epilepsy clinics as a separate type of offer.
How does it work when you've got these teenage epilepsy clinics, which sounds really cool, but then how do you help them make that transition out of pediatrics to adult care?
Gradually, and starting early. So I think sometimes it's perceived as transition as handover. You do something at the end of pediatrics, but that always goes wrong. And sometimes they can be left high and dry, and they land in adults, or don't land, but it's always a sort of shock to the system. So increasingly, we've been trying to think more about young people's epilepsy services, beginning from maybe age 11, 12, beginning to get them to think independently, make decisions for themselves, understand their epilepsy, speak for themselves, maybe see us on their own first, and then do that gradually. You can track it over time, so that you don't suddenly say we're going to treat you as an adult now. Some want to be, and they come in and you can tell they're behaving like an adult, they're thinking like an adult, and they're just ready to go, and the parents can take a back seat. But
they want to kick them out. Like, I want to do this on my own, mate. There are certain things that I want to tell my doctor I really don't want you hearing.
Yeah, for sure. Yeah, and then you have to be ready. So you have to be able to. It's really easy to keep treating them like a child if you're not careful, or the system can perpetuate that. So sort of trying to see through that and see where they're at, and allow them to get independent. Because my impression is that epilepsy really can stifle young people's journey towards, and there's nothing more, particularly the teenage onset epilepsies, you're just finding your feet and trying to work out who you are in the world and how it works and act independently, and then suddenly you get this unpredictable, embarrassing condition. I think it's one of the cruelest health problems for teenagers, for sure.
Do you know what? It's really cool that you said that, because I was having a conversation with somebody. It was a few months ago now, but it really stuck with me. And it was with a person who developed epilepsy as a teenager. And they were telling me about basically what you just said, how challenging it was to kind of change your whole life and try and accept that maybe this condition will stay with you. Maybe it will sod off in a bit. You don't know. But until you know, then you just got to change everything. And yeah, it can be really embarrassing. It changes your social. Anyway, I was comparing that to my own situation, where I was diagnosed when I was really little, and I'd been having, seizures years prior to diagnosis. So as horrid as it is, and it's something that, because I've grown up with it, and because my life has been at least partially molded by it, it's not a shock for me when teenage years are so horrid anyway, in many ways, so challenging. And so it's easier in a way for me to cope with it at that age than it is for them. And I hadn't really thought of it before until I was speaking with people who were diagnosed at a later age. And so it's really good that yourself and no doubt your colleagues recognise that, because I don't think it used to be recognised in the past.
I find often it's often they just talk about people with complex epilepsy, and clearly they have a bad time. But even everyone with epilepsy, even if the seizures have completely gone away, that fear of having the next seizure can be really difficult for them. And then there's all the other stuff. So increasingly their mental health, their well-being, all the things that traditionally we don't talk about often are the main impactful things. So not just the seizures, but trying to get the health system to hear that, see that, focus on that is really challenging. And it's been interesting with COVID. We do see, because normally I'd see people in clinic and it's a really sterile, artificial, constructed environment, and it's made me realize how you don't really see people as they are. So when we've started to do more video clinics, it's been for some they don't like it, but for others they feel so much more comfortable. They're in their own home, they're in their comfort zone, they're speaking to video, which they're used to doing, and you see them in a completely different light. So it's been interesting to see a different side to people through the pandemic.
So I just literally this morning did a talk with for Neurological Alliance at Royal College of Psychiatry, and I was saying how for me lockdown has been, I'm lucky that I don't have children to look after and stuff like that, but I've actually found it quite relaxing, and I haven't had to travel to appointments, which can be really tiring and stressful. So I've been able to like sleep longer in bed in the morning, which is really good for, as far as the epilepsy and the mental health comorbidities are concerned. Have you had any feedback from patients and families regarding that? Like, has there been a positive aspect to remote appointments in that way?
Yeah. For the families who love it, they love it. And so the young people before would, some of them who wanted to come independently, they're not driving, so they had to come on public transport, and it'd be they had day off college, and so it was a massive impact. And you don't see that if you're seeing them for half an hour in clinic. You don't see how much of their day it's removed. So yeah, see them at home. I've seen families in the front seats of their car. The parents go into the school, get the child out of the class. They sit in their front seats. They have a video. It's a bit like carpool karaoke, and you see both. but it's quite nice. There's a sort of equality there, and you find the young person speaks for themselves, and the parent says they're. So yeah, it's been nice. So I don't want to lose all that. So.
I guess it's neutral territory as well. Yeah. Actually, that is really good. So you're just making me think of the couple karaoke with Bruno Mars and the one with Adele. Is it as good as those two? Because those were fabulous. Watch out, you'll have patients and families singing for you. That hasn't happened, right?
There's less music. There's less music, to be sure.
Yeah. So can I ask, you've told us a bit about this already, but how does it work helping patients and families with their psychiatric comorbidities? I think generally professionals like yourself don't have as much time as you would like with patients and families. So how do you help them if you have a suspicion that they might not be well, or if they've told you that they have depression, anxiety? What do you do?
To be honest, with the current state of health service, we struggle. The health service isn't equipped to properly support young people's mental health and well-being. So over time my interest with epilepsy has grown into struggling to support people properly, and thinking how do we shake up the system. I can do my best in clinic, but the whole landscape for epilepsy needs to change. So my audit improvement work has been trying to support changes in the landscape, so that you can begin to help families better than just what you can do on your own. And interestingly, that's over, we've been doing that for over 10 years now. And initially the focus was around seizures and medicines and avoiding misdiagnosis. But now it's trying to think, how do we get mental health embedded into our services? What should that look like? And we're not there yet, for sure. But we can recognise it, so I think you can hear, to start off with, you can go looking for mental health problems and be ready to hear about it and show interest and be curious and not just be distracted by seizures and medicines. So you can start off with that, but then what you do to support the young person is really tricky. And there's some models coming up that are nice, so you hear about some services that are getting there with getting mental health provision there in clinic or where the young person needs it, but so often it's really difficult. And CAMS are, the children's mental health services are overwhelmed, and they're so busy trying to support inpatient mental health care and kids with suicidal problems or other more classic mental health problems. The young people with epilepsy find it hard to get the support there, and then when they do, often the epilepsy is seen as I don't know, for whatever reason. Sometimes the epilepsy is used as a reason not to do what you tend to do. If you're treating some person who didn't have epilepsy for the same problem with their well-being mental health, they might get one package, but because of the epilepsy, they don't always get offered the same things, because there's this question is, maybe it's to do with the epilepsy, maybe it's the medicine, maybe I think they get neglected in plain sight sometimes, not always, but I think that's my impression. So yeah, it needs to be really shaken up, mental health provision for people with epilepsy, for sure.
I feel that personally, and on behalf of many people that I know, when we say that mental health issues, and whether you're a child or a supposed adult, there's no point in having controlled seizures if you are suicidal, or if you're so anxious you can't leave the house, because honestly, I think that just says it really. And also, surely it needs to be recognised that further investment and provision for the mental health of children affected by epilepsy and mental health comorbidities will save money. Like, not initially, but it will save the taxpayer money. Like, for instance, if I'd have gotten help years ago with my mental health, I swear I would not need as the help that I need today. And it's very short-sighted, do you not think?
Yeah. I think there's loads of money to be saved with. If you do epilepsy care good, you can save loads of money. So it's really doesn't make sense sometimes to that things aren't improved when you can make such a difference and save money at the same time. In the audit work I'm involved with, we know that maybe about 30% of young people have some type of mental health problem diagnosis, but we found in our audit that diagnoses were being made in less than 10%, so it wasn't being seen, let alone supported. So it's sort of the system we're working in is still not recognising and finding the problems, and so you then find them later, or they come to you in a more advanced form. And our audit has changed its focus over time, and that's been largely the young people who've been involved telling us loud and clear that we need to be looking at different things. And the two things they've told us we need to focus on more is mental health and services being contactable. This ability to get help and support in between appointments, in between admissions, and then have a focus that helps their mental health and well-being. So we've tried to focus our improvement work increasingly on those two things.
What would be the procedure if a child wanted to speak to you without their parents present, for whatever reason? Because often mental health issues involve families, right? And often, especially at certain ages, you just don't want your parents to know of certain things that you're experiencing. gone through, like they might want to mention to you that, you know, I think, did I have a seizure in my sleep because I woke up and I'd wet myself? Or I've got a girlfriend or a boyfriend. What if I have a seizure during sex? I wouldn't want to say that in front of my parents. Like, what do you do in that situation?
Yeah, or your doctor. So yeah, so I
Yeah,
work
well,
close.
yeah.
You know, it's a vulnerable. It makes you vulnerable, doesn't it, to have some of these honest conversations? Yeah. So in the clinic, you can do something. So so you can assume that the young person may want to have an independent consultation with you, and offer that routinely within your teenage clinics. Do you want to see me first? You can and then try and run your clinic. I do them together with Kirsten, who's our epilepsy nurse. So we do it as a double act, and then usually it doesn't. Usually the young person has already spoken, because they have a relationship with the specialist nurse and using WhatsApp and text, and there's a sort of ongoing relationship between clinics, that conversation has already begun. And then there can be an expectancy that they can say, safely talk about it. So yeah, you don't want to try and solve everything in the clinic appointment. I don't think, but you can do a lot to make the clinic appointments suitable for that type of conversation. But you're never going to create a clinic that properly supports young people with these types of conversations. Yeah. So increasingly, I think it's this: how do you support people in between their appointments? What does that relationship with the service look like? How does it have a human face? How does it feel safe? How can the young person independently speak to the team? And then digital, the attraction of some of the digital solutions is increasingly we'll be able to use that space. And we're just testing at the moment something using the NHS app where young people directly can begin to message the epilepsy service professionals they know directly. We've only just got going, so it's in the early stages. But the ability to confidentially and securely message your team, and then see your letters digitally and see care plans digitally, and have that to be able to carry your health around in your pocket, and put your seizure frequency into the same system. That's where we're trying to get to, but it's early doors for that. But it's something about the contactability, I think, not just how you create your teenage clinics.
That's really cool. Like, I wish I had that growing up. That would have been so good. Although, I don't know, something that might have held me back is that I know that my parents have access to the records. So then it's...
Yeah. So you need to create a confidential space, and then how do you do that? So I think how one person wants to communicate is probably going to be different from another person. So you need a mixed model, I think. But it's not straight.
No,
it's not straightforward.
Nothing is.
But it's
that was straightforward as the brain.
Yeah, but you got to do it. This is what I think people with epilepsy, like no other, need this type of complex service.
I'm just thinking of a chat I had with Rohit Shankar a couple of weeks ago, and he was talking about a family who had a child with epilepsy, intellectual disability. It was a really challenging situation, and they'd been saying to him that their child was having a certain type of seizure, which can be invaluable for you, right? But they had said it was basically they were wrong. They said it was one type, and it wasn't, and so that meant that Rohit could not provide the treatment that person needed, at least for that period of time, until he actually knew that, wow, no, they're not having that type of seizure, they're having another. Do you come across that sort of thing? And if you do, how do you address it?
Getting the diagnosis right is really important. So and it's not a single diagnosis. There's so many different types,
right.
And it's in the story. And so hearing the story for yourself, hearing what the seizures are really like, getting a video if they've occurred in school. You need to be hearing from the teacher rather than a second hand via the parent. So it's getting an accurate story, and you'd have thought that's easy in this day and age, but actually there's so much that muddies it, and sometimes people will tell you the story in the way you think the way they think you want to hear it, so they alter it, the words, and they tell you what you want to they think you want to hear, so you have to pick that. So but that's why I like that sort of trying to get under the, just get under the surface and see what's really going. And it's really rewarding because, when you when you get a clear description, usually the seizure type lights up and it becomes obvious, and then you get more information, and then over time you can work out what type of epilepsy it is and then what the best medicine is. So but it's never in a single moment. It's never really a light bulb moment. It's a sort of a gradual awakening.
And it's like a massive jigsaw, isn't it? Because there are all these different bits. Like, and
you get it wrong sometimes. You think one thing, and you've only seen half the jigsaw, and then you get a video through, and it's different than you're expecting, or then you see another type of episode, or you see another type of video that was at night rather than day. So it's a jigsaw where you're getting the pieces incrementally over time. There's pieces missing. You never get the whole jigsaw. So
it's like you're an investigator, really, as well, isn't it? And like a private health investigator. I was thinking, what percentage would you say of your patients, and perhaps it would be split up again depending upon the type of epilepsy, but show no irregularities or abnormalities in their EEGs? Because, like, for instance, when I had my first EEG when I was little, no abnormalities shown at all. I wasn't having a seizure at that time, and there was nothing funny going on in the background in Trictal. So, and then I'd had another one another day, showed nothing. And it wasn't until I was having video telemetry in hospital for the second time that I happened to have a seizure then, thank goodness, the only time you want a seizure. And then they could see the abnormal activity. But it wasn't. So what do you do with these people who show no abnormalities?
Well, so it's maybe about half of the young people.
Right?
But we sort of know that. We know that the EEG isn't often going to give us the answer. If your question is, have I got epilepsy or not, then the EEG is a really rubbish test. If you think, I'm pretty sure from my story, the videos, this is epilepsy. Now I want to get into that in a bit more detail and know what type it is, then the EEG, even if it's normal, is helpful. It'll push you to saying, I think this is a generalized epilepsy. I think this is a focal seizure. I think it's this type of focal seizure. So the EEG takes you further. So normally EEG is fine. It doesn't throw you if you understand it in the right way.
So it's not worthless if they don't have an EEG. Have a seizure during the EEG.
Oh yeah, that's useful, but it's rare. I mean, most 20-minute, 30-minute EEG, you catch everything but the seizure usually. But it gives you clues and it tells you something. But I think that was the problem 15, 20 years ago. There was an over-reliance on EEG. People didn't really understand the features of epilepsy. So they thought every shaking episode was an epileptic seizure, and then EEGs can be abnormal in people without epilepsies. And so there was this culture, I think, of people getting misdiagnosed with epilepsy. But we've moved on stacks since then. In our latest audit publication in July, the rates of misdiagnosis have completely dropped, we think.
Wow,
so compared
that's so good.
Compared to when we started, maybe 2010, we started the audit. So over the years, as far as we can tell, the rates of misdiagnosis have really plummeted, and then that's what's made us sort of shift our focus now.
Yeah, no, so good. Because I was talking to a while back Sandor Beniksky, who was saying about 30% of people with the diagnosis of epilepsy don't have epilepsy. I was like, wow, imagine being doped up for your whole life with drugs or treatment that is not going to control the seizures you do have because it's not epilepsy. That's just crazy.
That still does happen, but I think it's getting better. So we think the sort of rates of misdiagnosis in more expert services are probably more approaching 5%, whereas in non-expert service is around 30%. So so if you can get your service to have expertise and be well resourced, I think you can get your misdiagnosis rates really down. So that's what we're trying to work on. What does expertise look like? What does a good clinic look like? Who needs to be in it? How do you relate to your families? And all those things can help with misdiagnosis. And again, there's money to be saved there. If you're misdiagnosing people and whacking them on epilepsy treatment, you're wasting loads of money, and you're not treating their problem, and you're giving them all the stigma and baggage of epilepsy, and they've got something else. So,
I'd rather have any stigma, focus on psychiatric issues if that's what it was, so that I could address them. So, and this is a bit of a touchy question, but do you have any patients, or have you had any experience with children who have epilepsy as the result of parents who have been too closely related?
So the parents are genetically
too close.
Related.
Yeah.
Not epilepsy on its own. So I think usually those young children will have a metabolic problem, another genetic diagnosis of which seizures are a part. There's a whole range of metabolic problems in children where close relatives make it more likely that the child has an expression of that disease. So there's quite a few, but they're rare. And most epilepsies, that's not a question. So even the genetic epilepsies, usually they're expressing themselves, and it's nothing to do with consanguinity. So it's a rare situation, and it depends where you're working. I think because obviously there's cultural influences on the likelihood of consanguinity. So some services have more metabolic problems than others. More genetic problems than others. I think each geographical area of the country have their own flavour of epilepsy and related problems, and it's all quite different, and their own demographics. So when you're making an epilepsy service, what's right for one area, it's like it needs a completely different picture, I think, for different areas of the country. So thinking about it.
Do you know what? I confess, because I love the idea, the topics of genetics. And I thought at one point, I know it's unlikely statistically, but, were my parents a little bit too close genetically? Who knows? Because it's when you have refractory epilepsy, you go through all these thoughts, like, what could be the cause? Will I ever know the cause? And sometimes I think, and maybe you experience this with patients and families too, like when you say to them, do you know what, dude, I'm sorry, at this present moment, I can't provide you with a reason for your epilepsy.
Increasingly, the genetics is opening up.
Yes.
So, we'd only occasionally think about looking for a genetic diagnosis 10 years ago. Whereas really now, most children, certainly children under 5, if it's not obvious what's causing the epilepsy, we need to be going hunting for a genetic cause. And we've only just started with that. It's exciting, but it's going to be different 5 years from now, 10 years from now, and then we'll move to whole genome type model. Where you almost certainly you'll already have access to the person's genome, and then you can interrogate that and go looking for diagnoses off that resource. And what's that world going to look like?
So exciting, isn't it? I know some people are scared of it, but I just think it's amazing. Like you said, what are we going to find out in 5 years? What's
disappointing sometimes is how the genetics doesn't give you the answer. So sometimes it can explain things, but then you can find people with the same genetic problem and they've not got epilepsy at all, or it's completely different. So this relationship between who you are and your genes is not straight cause and effect. It's weirdly complicated. We're much more than our genes.
Yeah.
My work has been really about the phenotype, not so much the genetics, but how it is for the person, how it expresses itself in them. But the genotype and the linking that up with the phenotype is going to change things considerably. I think not just epilepsy, but all sorts of health problems.
And then hopefully help with the psychiatric comorbidities too, so you can find those links and...
I'm sure we'll find genetic predispositions to all sorts of mental health problems.
So exciting.
It's not going to suddenly solve everything. I think, it will give us even more insight, but it will create a different type of complexity.
And that's such an important point, really, isn't it? Because people, who aren't familiar with, whole genome sequencing or whole exome sequencing presume that if you do that test, we have all the answers in the world and you're going to cure me. Oh, if only,
Yeah. It just moves the why. There's still always a why, and what now. But more information helps for sure. But it never completely satisfies the issue. And you can still never see the future. However much we know about, you still can't look. And that would be the best intervention if we could have for epilepsy. If you could, well, maybe I don't know, time, some sort of time travel device. I don't know whether we can invent that or.
Yeah, be like, oh my goodness, I show my age, but I was just thinking Back to the Future reversed, or Bill and Ted's. But apparently they've made another Bill and Ted. I haven't seen it. Have you heard of it? There's new Bill and Ted's like Bogus Journey or something.
Oh yeah, I've not seen it.
Yeah,
I've seen Back to the Future too many times.
I know. Classic. Don't judge us, people. Classic. And if you haven't seen it, you've got to watch it, man. Even if it's just for the cheese.
A DeLorean car in epilepsy clinic. Go ahead, see how the medicine's going to work. Go back, be able to see the seizure. That would be fantastic.
Oh my God, wouldn't it? And you would have like people in their late teens and probably parents as well jumping in that DeLorean as well. Just
and the jetpacks. That came. The later one. Things that fly. That they're just missing in our teenage. The electronic scooters are one thing, but jetpacks and time machines.
Something different. So if people want to support you and in what you're doing and the work that and I'm talking about the work that you're doing to get more support for both clinicians and patients and families, those who are affected by epilepsy, how can they do that, or how can they find you?
Yeah, so the audit work is Epilepsy 12. So if you Google Epilepsy 12, which is all one word, you'll find the College of Paediatric website. And there's all the different streams within that program are discussed on that website. So we've got a youth advocacy program, so teams of young people who do their own analysis and research programs and do their own platform presentations and are on the different boards, and so drive the program. If you're a professional, look at your own results. How is your local service doing? What can you do? Where are the changes needed? If you're a commissioner, how are the services in your patch performing? Who needs support? We've tried to do the audit data to show the whole system. What are clinics like, what are trusts like, what are regions like, how are we doing nationally, what's the workforce like, and see the gaps in the system. So helping us gather the data and looking at our results and working out, what can I do, how can I use this data? Because I think we've known there's problems for years, but there's been a silence around the problem, or people have felt the problems and lived with the problems, but when we've gone looking for the actual evidence to describe the problem, to make the case for change or the economic case for change, it hasn't been there, but it is now. The paper we published in July just gone, we'd gathered the story for 6,000 children and young people in England and Wales who've presented with new seizures, and what happened over their first year, and what went well and what didn't go well, and then we've broken it down geographically across the country, so you can see at as much detail as you want how the quality of care is across the country. So now we're at a point now where it's what we do about it. So it's not trying to know what the problem is, it's getting on and solving these problems. And we still need more epilepsy nurses, we need mental health in clinics, we need teenage clinics, we need good pathways to neurologists. There's loads to do, but we can see what the problem is now. So there's loads of ways to join in.
How can anybody listening, could they present this issue to their local MP to support and refer to your work and as a empirical evidence, like we have this issue, what are you going to do about it?
Yeah, and because the voice of the person with epilepsy or the family is always listened to, always, as a young person or as a parent, you can look at how your service is doing. You can ask questions to your service. What are you doing about this? You can write to your chief executive. You could go to your commissioning group. You go to MP. We want to work with families. We want to work with families, but they can help us by telling us what they need and what they want, and making their voice heard. And that's the idea. Giving them data can mean that they've got informed. They're informed. It's not just their experience. Their experience is really important, but it's experience and evidence together, and it's really, really powerful.
And also, I think it's quite reassuring or comforting for other clinicians to know that somebody else is singing from the same hymn sheet as themselves, and the same goes for carers and patients. We're not the only ones who are getting quite frustrated with this. We have people like Colin Dunkley speaking for us, and then if we get other clinicians involved too, then we can. I just feel like there'll be this big positive crowd working for change to better the lives of so many people, and not only patients but all their families.
We talk a lot about clinical networks and working together in collaboration, but we need to think that's not just a professional thing. That's a network, including our families. Families are at the front. Embedded. It is a network of society, and reaching out into schools and social. It doesn't just stop at health or at the doors of the clinic. So rethinking what networks are and connecting people and getting a common voice. Most people are working together and trying to solve the same problems, but things get in the way that shouldn't. But I think there's lots of potential. The NHS plan that's beginning to be talked about again now after COVID has got some good stuff in there about epilepsy care and mental health and transition. So
great.
So we need to get behind that. The ICSs, the commissioning groups that are beginning to crystallise, are beginning to show interest in epilepsy and other long-term conditions. So there's definitely channels and opportunities there, and people beginning to listen. But we need experience and evidence to be shouted out for sure.
But shouted out in a productive, I think, constructive way.
Exactly.
There are places for moaning, but I don't. We're working together on something like this. We need to try and be like, okay, this is terrible, but wouldn't this be cool? And wouldn't that is so important.
It is. When you talk about quality, it's really hard to not. You can end up quite downtrodden and depressed because you're sort of trying to criticize yourself and the system, but you've got to see where improvements needed. There's got to be a facing up to where service needs to improve. You've got to do it. So, but you can do that constructively. I agree.
Oh, thank you so much for what you do. Honestly, this has been such a cool, fun chat and really uplifting to hear about what you're doing. And so much of us can learn from you and your work. So I will put the links, or the link to the website that you mentioned, Colin, below this recording, and also to your Twitter. You've got a Twitter page. It's a really cool profile picture of half his head, so you won't be able to miss it. Thank you so much to Colin for telling us about his work and sharing with us what a passion he has for improving the lives of children and their families, in fact, affected by the epilepsies. It is really heartwarming, and I can say that from a personal perspective as a kid who grew up with epilepsy, as well as a supposed adult. It really warms my heart. Next week, we'll be chatting to Alexandra Fonzi, a genomic and molecular biotechnologist from L'Aquila in Italy. And she'll be telling us about her epilepsy research project in the field of whole genome sequencing. Follow me on Twitter, LinkedIn or Facebook, and we'd love to hear from you if you have any thoughts about today's show. Do subscribe to our podcast and know that we are always trying to improve what we are doing here for the programme. I'm Tori Robinson. Thanks for listening.